Hello, everyone. Thank you for joining us today in this webinar, where we are going to talk about how alcohol drinking behavior changed during the COVID-19 pandemic. We are a group of 3 health economists at RTI International, and we've been doing a lot of alcohol research for the past several years. And our research is related to alcohol drinking patterns. So we wanted to see if and how the current pandemic had any impact on drinking patterns in the United States. Presenting today are myself, Carolina Barbosa, and also Bill Down, and Alex could not join us today. Several people have asked us why we felt the need to do this survey and with such urgency. Well, we realized that no existing national survey like the BRFSS or the National Survey on Drug Use and Health will be timed to capture the impact on alcohol consumption of all the changes that the pandemic brought, like the stay-at-home orders issued in March and also changes to alcohol distribution. So RTI funded a survey to assess changes in alcohol consumption from before to after the onset of measures to combat COVID-19. We are here today to show you the results of that survey and discuss the implications to public health. I want to start with a little bit of background on alcohol consumption and related harms in the US. You are most probably familiar with all of these. In 2018, about 70% of the US population aged 18 and older, and we're talking about 174 million people, consumed alcohol. And more than half were current drinkers. Also in 2018, about 27% of the adult population reported binge drinking in the past months. And the trends in consumption show an increase in the prevalence of alcohol use between 2000 and 2016, with even higher increases in binge drinking, particularly for women. We all know that drinking too much is not good. However, many people are unaware of the degree to which excessive drinking can damage our health. Alcohol use is causally linked to more than 200 acute and chronic health conditions. And alcohol consumption contributed to an increase of 62% in the number of emergency department visits in the United States between 2006 and 2014, and especially among females. Between 2006 and 2010, about 88,000 US annual deaths were caused by excessive alcohol use, making it the country's 4th leading preventable cause of death, according to the CDC. And there is also evidence that between 1999 and 2017, death rates from alcohol increased by over 50%, with the largest annual increase occurring among females. And finally, the social costs of excessive alcohol consumption are huge. It's associated with about 250 billion in 2010. These costs come from losses in workplace productivity, healthcare expenses, criminal justice expenses, motor vehicle crash costs, property damage, etc. Now, let's navigate through the many changes in policy that happened as a result of the pandemic. Across the United States, starting in March, a range of policy responses were implemented to limit the spread of COVID-19. Most states enacted stay-at-home orders, banned public gatherings, enacted physical distancing measures, and closed schools and non-essential businesses like bars. Most states also restricted dining at restaurants. And what about alcohol policies? Let's first have a snapshot of the situation before the pandemic. Before the pandemic, most states sold beer and wine in food stores. And this remained the case after the pandemic because food stores were considered essential. As for liquor, most states sold it in controlled outlets and 20 states in food stores. Now, most states that declared stay-at-home orders included liquor stores as essential businesses. Also, in an attempt to stimulate the alcohol industry economy, several states provided temporary privileges for off-premises alcohol deliveries. Most of you know this, but let me clarify the distinction between off-premises and on-premises. Off-premises are places where alcohol is meant to be consumed off-site, for example, liquor stores, groceries, and drugstores, whereas on-premises are places where alcohol can be consumed inside, like restaurants and bars. And the map here shows the 15 states that relaxed off-premises restrictions by adding curbside and or delivery for off-premise sales. Prior to the pandemic, 28 states permitted on-premises operators to deliver some alcoholic beverages. However, to our knowledge, no states permitted restaurants to offer mixed drinks to go before the pandemic. And the graph here shows how during the pandemic, 24 states permitted the sales of mixed drinks to go from bars and restaurants. Also, some of those changes were not for the full state. So changes in these policies were sometimes at the city level. And these policies keep changing, and guess what? The map is no longer up to date. For example, Michigan now also added cocktails to go. And even though these changes were said to be temporary, they might be here to stay. For example, in late June, Iowa became the first state making to-go cocktails permanent. Now, what do we know about alcohol consumption in the midst of the current pandemic? Let's first start with sales data. I'm sure you all read media reports of changes in alcohol sales. Off-premise alcohol beverages sales increased considerably since the stay-at-home orders and the relaxing of alcohol restrictions. However, this spike has been uneven, and the increase in off-premise sales might not have been enough to offset the fact that practically every business that serves alcohol to drink on site was closed for 3 months. There are also reports that consumers are spending less on alcohol because of transferring purchases from on-premise to off-premise, and also that people are buying cheaper. But overall, there is ambiguity with regards to the overall effect of sales changes on consumption. Are people stockpiling? Are people increasing immediate consumption? Has the way people drink changed at all? So, what do we know about alcohol consumption? Several messages exploded across the media stating increases in alcohol consumption related to the increases in sales, and also justifying this with the social isolation, stress, changing work patterns, and the overall economic turmoil. These increases have also been hypothesized based on the impacts of previous disasters on alcohol consumption. So after the terrorist attacks of September 11 and also Hurricane Katrina, there were sustained increases in alcohol consumption and also increases in the prevalence of alcohol use disorders, binge drinking, and alcohol attributable violence and deaths. Still, the weeks of isolation imposed by stay-at-home policies and the scale of the current pandemic are unmatched by these recent disasters. And I ask again, has overall consumption really increased? And if so, did it change more in some groups than others? Can some people be drinking more and in more dangerous patterns? And these questions take us to the RTI alcohol survey. Given the proliferation of anecdotal data on increased drinking and the evidence of an increase in off-premise alcohol sales, we realized that the best way of filling the gap in knowledge in drinking patterns was to do a survey and to do one quickly. And over the next slides, I'm going to talk about the survey and how we analyze the data. Our survey was motivated by 3 fundamental questions. First, given what we know about the policy changes, the stay-at-home orders, the changes to alcohol restrictions, how did overall alcohol consumption change? Second, we know that the effect of alcohol on health depends on how much we drink and how often we drink. I mean, it's not just overall consumption that matters, but also drinking patterns. 2 measures of what constitutes excessive drinking include binge drinking and drinking above recommended guidelines. We're going to use those 2 measures to look at how excessive drinking changed at the onset of the pandemic. And third, we also know that drinking and related harms vary by socioeconomic groups and other characteristics. So we're going to assess changes in drinking patterns by several factors, such as gender, race, ethnicity, existence of kids in a household, employment, mental health, and alcohol problems. Here's a bit of background on the survey. We work with Ipsos to administer the survey. Ipsos has a standing panel the knowledge panel of more than 55,000 adults who respond to survey questions at scheduled times. This panel was recruited through an address-based probability sampling methodology to produce nationally representative estimates of the United States. This is a probability-based approach that also includes cell phone-only and non-internet households. We use the government and academic omnibus, which has a 7-day field period. And respondents were invited to our survey throughout the second week of May. The survey had several questions with regards to alcohol. Because consumption questions ask about drinks, the survey first defined what a standard drink is, and we'll talk about that in a bit. And then we asked several questions about drinking in April, followed by the same questions about drinking in February. We also asked questions for these 2 months about mental health and employment, and then we asked questions about lifetime alcohol experiences. As a standing panel, we also had access to information on several other variables, including demographics, household composition, and counting of residents. Here, this slide shows how a standard drink is defined in the United States. One standard drink contains 14 grams of alcohol. It's a 5-ounce glass of wine at 12% alcohol by volume, for example. Here is a summary of the alcohol consumption measures. It is important to pay attention to this slide because it lays out the different dimensions of drinking that you are going to see again when we talk about the results in a minute. The first two, the frequency of drinking and the usual quantity of drinks, are the bedrock of assessing alcohol consumption. The next two dimensions account for alcohol consumption on days when people drink more than they usually do. Use the first 4 measures to calculate average drinks per day. The 5th measure assesses binge drinking. We then use algorithms to convert the survey questions into 3 main drinking outcome measures. 3 of them we will be presenting in the results today. In addition to alcohol consumption, we also collected information on mental health, employment status, and alcohol-related experiences. For mental health, our survey incorporated the PHQ-2 and GAD-2, which are brief screens for depression and anxiety. The screens consist of 2 questions each that ask how often the respondent has been bothered by problems related to depression and anxiety. For employment, we asked about full-time, part-time work and measures of being out of the workforce, including unemployed, retired, in school, etc. For lifetime alcohol experiences, our survey asked respondents whether they had ever been advised by a doctor or the medical professional to cut down drinking. We also asked whether they had ever engaged in treatment or self-help services like Alcoholics Anonymous for alcohol use. And if so, we asked about the exact type of services they received. Because of the restrictions in the length of the survey, we did not include formal questions for the diagnosis of alcohol use disorders. And who completed the survey? Almost 1,000 people were surveyed. In our analysis, we're going to focus on 555 or 55% that they reported they drank in February. We included analysis drinkers in February because we wanted to see how drinking patterns change amongst drinkers, and also note that 55% drinking is the same proportion of current drinkers found in the 2018 National Survey on Drug Use and Health. The analysis we performed was straightforward. We applied survey weights, used standard statistical methods like linear and logistic regressions to compare the estimates for outcomes in February to estimates in April. And we chose 3 main outcomes to report here today, and those are average drinks per day, percentage of people exceeding drinking guidelines, and percentage of people binge drinking. And we report those outcomes for the overall population and several subgroups. Bill is going to define how we computed these outcomes in a bit. In addition to assessing changes in those 3 outcomes, we also assessed which of the quantity and frequency dimensions that I showed a few slides ago contributed the most to changes in average drinks per day. And now, Bill will talk about the results of the survey, and I'll come back to wrap up our discussion.
Thank you, and good morning, good afternoon, and good evening, everyone, depending on where you find yourself. As Carolina noted, we'll begin our discussion of results by reviewing our three main outcomes among the sample of respondents who reported drinking in February. I'll first briefly describe the three outcome measures that we're going to discuss today. The first measure, drinks per day, is a straightforward measure of alcohol consumption. The drinking guidelines, the second measure, are those issued by the US government. These refer to consuming more than 4 drinks per day and 14 per week for men, and men aged 18 to 64 years, and more than 3 per day and 7 per week for women, and men aged 65 and older. Finally, binge drinking, the third measure, refers to drinking 5 or more drinks in a 2-hour period for men, and 4 or more drinks in a 2-hour period for women. Before we look at the results for drinks per day, I'd like to describe how we calculated it. We followed a similar approach to the NESARC survey, which accounted for typical consumption and more than usual consumption. First, we multiplied how much people usually drank by the number of days they drank. Then we accounted for excess drinks on days when people drank more than they usually do by adding the number of extra drinks consumed on those days, multiplied by the frequency of drinking more than usual. The resulting number was the total drinks consumed in the month, which we then divided by 30 to get drinks per day. We found that average drinks per day increased by 27% from February to April. We consider this to be a large increase, and it was also statistically significant, which speaks to the precision of the estimate. A plurality of respondents, 41%, reported drinking more on a daily basis in April, compared to 30% who drank the same amount in February and April, and 29% who drank less in April. Another way of looking at the change over time is thinking about it in terms of drinks per week. The average respondent drank more than 1 extra drink each week in April compared to February. Among the 41% of respondents who increased their drinks per day, the average person drank more than 5 extra drinks per week. One thing to note about this finding is that we included in the April estimate people who did not drink at all, which was about 10% of those who drank in February. This means that the change over time would have been even larger had we looked at people who drank in both February and April. Now we'll shift gears to look at drinking that has the potential to harm health. We found a large and statistically significant increase in the proportion of respondents who exceeded the guidelines of no more than 4 drinks a day and 14 a week for men, and 3 drinks a day and 7 per week for women. From February to April, there was a 21% increase in the percentage of people who exceeded these guidelines. Finally, we'll look at the third of 3 main outcomes, the measure of binge drinking, which is more than 4 drinks in a 2-hour period for men and more than 3 for women. The percentage of people binge drinking increased by 26%, again a statistically significant change. This means that across our 3 outcomes, we observed increases of about 25% in total consumption as measured in drinks per day, drinking above recommended daily or weekly guidelines, and binge drinking, which is drinking a lot in a short period of time. Now we'll take a deeper dive into the 3 outcomes. Recall the research questions posed earlier. We've established that across all respondents, drinks per day, drinking in excess of recommended guidelines, and binge drinking all increased considerably. But we want to understand the nature of those increases. How did they change and for whom? For each outcome, we'll examine whether changes varied across respondent subgroups. And in addition, we'll look at specific dimensions of drinking behavior that were behind the overall increases we observed. We're going to begin with a drinks per day outcome for each of 6 respondent subgroups. To orient you to this slide, each cluster of 2 bars represents a subgroup. The blue bar represents average drinks per day for the subgroup in February, and the red bar for April. 95% confidence intervals overlay the bars. The leftmost cluster of bars represents the change for all respondents, which we've already discussed. Before we look at the difference in change for males and females, which is the focus of this slide, I want to point out a characteristic that is consistent across all subgroups. That is, the red bar is always taller than the blue bar, meaning that for every subgroup we examined, average drinks per day increased from February to April. Now, focusing on males and females, we found that the increase in drinks per day was roughly uniform across these 2 groups. However, as the average woman drank about half as much as the average man in February, the additional 0.2 drinks per day represents a much larger increase over time in relative terms for women, about 40%, than for men, about 20%. Next, we look at subgroups defined by race and ethnicity. We find that white respondents increased their drinking by 0.17 drinks per day, compared to 0.21, 0.28, and 0.29 drinks per day, respectively, among Black non-Hispanic respondents, Hispanic respondents, and respondents who identified as neither Black nor Hispanic. As we saw with females, non-white respondents increased more in relative terms because those groups drank less than white respondents did in February. Now we consider respondent subgroups based on non-demographic characteristics. We stratified respondents based on whether they had children aged 0 to 17 in their household. About a quarter of the sample reported having kids in the household, and 3/4 did not. Respondents with kids reported an increase in drinks per day that was more than 4 times as large, on average, than the subgroup without kids. This difference was statistically significant at the 1% level. Next, we stratified respondents based on whether they were unemployed in either February or April. 8% of the sample reported being unemployed in either period. We found that drinks per day increased by nearly twice as much for the unemployed group compared to respondents that were not unemployed in either month. But the difference was not statistically significant. As Carolina noted previously, our survey incorporated the PHQ-2 and GAD-2 brief screens for depression and anxiety, respectively. We stratified respondents by whether they had a positive PHQ-2 or GAD-2 in either February or April. The positive screen group made up about 1/5 of the sample and had a larger increase in drinks per day, but the difference was not statistically significant. Here we stratified subgroups based on whether they reported evidence of alcohol problems in their lifetimes. As Carolina mentioned, we based this measure on whether respondents reported ever having been advised by a doctor or other medical professional to cut down drinking, or whether they had ever engaged in treatment or self-help services for alcohol use. We examined the group of respondents who answered yes to at least one of these questions, which made up 1/10 of the sample, compared to those who did not. Interestingly, we found that the subgroup that had evidence of alcohol problems increased their alcohol consumption very slightly, by less than 1 drink over the course of the entire month. However, the difference between this group was not statistically significant. Next, we look at how drinks per day changed by region. We stratified respondents into 1 of 4 census regions and had roughly equal numbers of respondents in each region. We found that drinks per day increased the most in the West region, where the average respondent drank about 0.35 more drinks per day, or about 10 drinks over the course of the month. The change in the West region was significantly larger than in the Northeast, where respondents drank an average of 0.1 more drinks per day in April compared to February. Now we're going to shift focus to how specific drinking behaviors changed in our sample. It's possible to increase one's own alcohol consumption by increasing how often one drinks, the quantity consumed on days when you drink, or both. Here we see that 31% of respondents increased their drinking frequency compared to 69% who decreased or stayed the same. Among the respondents that increased their frequency, the increase was considerable. They drank on about 7 more days in April than in February. Interestingly, the 31% who increased their frequency were drinking less often in February than other respondents, suggesting that the increase in frequency was driven by people who were not drinking very often before the pandemic. On this side, we see that for most respondents, usable quantity consumed was unchanged. However, the 1 in 6 respondents that increased their usual amount, it was a substantial increase, almost 2 more drinks per drinking day on average. Recall that we asked not only about respondents' drinking frequency and usual quantity consumed, but also about the most drinks they had consumed on any one day and how often they consumed that amount. These 2 quantity and frequency components, which describe more than usual consumption, are combined here into a single measure representing changes in behavior related to drinking more than one usually does. 27% of respondents reported an increase in more than usual consumption. The average increase among this group was 4.5 additional drinks over the course of the month in April compared to February. Here we use a tree map to stratify respondents based on which of the 3 dimensions of drinks per day they increase, and to show how changes in those dimensions are related to changes in drinks per day. In the tree map, the size of each segment represents the size of the group, and the color of the segment represents the average change in drinks per day within that group. The two segments on the left represent people who decreased their alcohol consumption from February to April or maintained the same level. The segments on the right, which together make up 41% of the area of the tree map, represent those that increased their consumption. The tree map suggests that increasing one's usual quantity was a necessary but not a sufficient condition to experiencing a large increase in drinks per day. The groups that increased their drinking frequency or max drinking, but not their usual quantity, situated toward the bottom right of the tree map, experienced relatively small changes in alcohol consumption. The groups that increased usual quantity and at least one other component increased the most, especially the group that increased all three components. In fact, the group that drank on more days in April than in February drank more on typical drinking days and consumed more on more than usual drinking days, accounted for more than 40% of the overall increase in consumption, despite making up only about 5% of respondents. We'll be coming back to that group a bit later. Next, we'll transition to our outcomes related to excessive alcohol consumption. We found that excessive consumption increased more for females than for males. The difference was large for both exceeding drinking guidelines and for binge drinking, and statistically significant for exceeding drinking guidelines. Among our respondents, women were quite a bit less likely than men to drink in excess of recommended guidelines in February, but they surpassed men on that measure in April. We also found important differences among race and ethnicity groups. We found relatively little change on these measures for white respondents, but large increases particularly among Black respondents. The percentage of respondents that reported drinking in excess of recommended guidelines increased nearly 6 times more for Black respondents than white respondents, a statistically significant difference. The percentage of Black respondents drinking in excess of recommended guidelines and the percentage engaging in binge drinking both more than doubled from February to April. As with drinks per day, we found that excessive consumption behaviors increased more among respondents with kids in the household than those without kids. The differences were not statistically significant, but were of considerable magnitude. Among respondents with kids in the household, the number reporting binge drinking in April was 50% higher than in February. We found that the increase in binge drinking was twice as high among respondents who reported being unemployed in either February or April compared to respondents who were never unemployed. However, the associations between employment status and excessive consumption behaviors were not statistically significant. Similarly, we found no significant association between excessive consumption behaviors and mental health status as defined by having a positive PHQ-2 or GAD-2 screen in either February or April. Average increases in these behaviors were larger for the group with no positive screens in either month. Finally, we found that excessive consumption behaviors increased more among people with evidence of alcohol problems compared to those without such evidence. This contrasts with what we found for average drinks per day, which increased very little for respondents with evidence of alcohol problems. A deeper look at this group finds that although average drinks per day did not change much for those with evidence of alcohol problems, consumption did change at an individual level, with some respondents reporting increased consumptions in April, offset by other respondents reporting reductions. The fact that excessive consumption behaviors increased among this group is cause for concern. Now we'll look at how measures of excessive consumption varied across census regions. As with drinks per day, we find that the percentage of respondents exceeding drinking guidelines increased the most in the West region. Interestingly, we found no change on this measure in the Northeast. The difference between the West and Northeast was statistically significant. We found a similar regional relationship for binge drinking. Again, the increase was largest in the West and lowest in the Northeast, but the difference was not significant. To conclude our discussion of survey results, we'll look at one more tree map. This one comprises only respondents who reported drinking more than recommended guidelines in April, about 36% of our sample. Once again, the size of the segment represents the number of respondents in the group, and the color represents the change in average drinks per day for that group. The 3 segments on the left represent people who exceeded guidelines in both months, and the segments on the right represent those who did not exceed guidelines in February, but did in April. Those two sets are further broken down into respondents who reported exceeding daily guidelines, no more than 3 drinks a day for women or 4 for men. Those who reported exceeding weekly guidelines, no more than 7 drinks in a week for women or 14 for men, or both sets of guidelines. We found that regardless of whether a respondent exceeding drinking guidelines in February, few respondents exceeded weekly but not daily limits in April. However, the key takeaway from this is that the largest increases in alcohol consumption were concentrated among respondents who reported new initiation of excessive drinking, rather than those that were already drinking more than recommended. In particular, large increases in drinks per day were concentrated among respondents who were not exceeding drinking guidelines in February, but exceeded both daily and weekly guidelines in April. You may have noticed that on the tree map we just looked at, as on the first one, we ended up with a single bright red segment representative of a large change in drinks per day. We analyzed the interactions between the two tree maps and found that to a large extent, these two segments represent the same people. Specifically, about half of the respondents in each red segment are also in the other red segment. We also found that taken together, these two segments represent 7% of respondents, but accounted for 65% of the increase in average drinks per day. Importantly, 80% of the red segment from the first tree map and 100% of the red segment from the second tree map did not exceed drinking guidelines in February. The takeaway message is that the changes in alcohol consumption reported by our respondents appear to be driven not by people who were already drinking heavily, but rather, in large part, by a small group of people who were not drinking more than recommended guidelines in February, but increased their consumption considerably. Most of these respondents increased their frequency of drinking, the amount they usually drink, and the extent to which they engage in more than usual drinking, such that they exceeded both daily and weekly guidelines for consumption in April. These results raise several questions about what may have caused some individuals to change their alcohol consumption, what the implications of increased consumption will be, and whether consumption and excessive drinking will remain elevated. I will now turn things back over to Carolina to conclude the webinar.
Well, these are a lot of interesting results, and we're not even showing you all the results we have. Thank you so much, Bill. Now, let's try to summarize these results and think of the implications these findings might have for public health and policy. We find that after the enactment of stay-at-home orders in many states and the relaxation of several state alcohol regulations, alcohol consumption, including drinking above the recommended guidelines and binge drinking, increased overall and across all groups assessed. We saw that almost half of the population who were current drinkers in February increased drinks per day, with 31% increasing frequency. We found that women, Black people, and people with children experienced the largest increases. We also saw large increases in consumption among those who were not drinking in excess of recommended guidelines in February. And this is especially concerning because this is not people who always drank a lot suddenly drinking more. This is people who drank within the guidelines, drinking a lot more. So what can explain the increase in alcohol consumption? Some studies predicted lower alcohol consumption during COVID, which would make sense due to the restrictions in place and closure of on-premises. And most studies that predicted lower consumption justify this with financial constraints and lower access to alcohol. But the reality is that there's a lot of international variation in the response on how to address alcohol use during COVID-19. For example, some countries, such as South Africa and Thailand, they ban alcohol sales completely, while governments in North America, Australia, and most of Europe deemed liquor retailers as essential services. So why did consumption increase? It is possible that the relaxation in alcohol policies, with off-premises being considered essential businesses, and also the privileges for alcohol deliveries, curbside pickup, and mixed drinks to go, offset the general lower access to alcohol. And together with enabled access, the media also reported how more leisure time, unemployment, and different working arrangements might have contributed to an increased consumption. Finally, another justification for increased consumption might also be a response to stress. And here we need to account for the increases in excessive consumption, particularly the findings of greater increase in drinking above the recommended guidelines for women than for men. Research shows that women are more likely to use alcohol to cope with stress, depression, and anxiety, and all these are a human response to the pandemic. And what are the implications of this increased consumption? Let's look at some short and long-term consequences. In the short term, the impact of increased consumption on accidents and injuries might go both ways. On one hand, driving decreases with higher restrictions, but that does not mean that drink driving decreases proportionally, and if enforcement decreases, the relative risk of alcohol in crashes might actually increase. Also, shifting from on-premise to off-premise consumption may increase the harms of alcohol consumption at home, which has been associated with domestic violence, violence against children, and child neglect. Finally, since alcohol consumption can weaken our immune system over time, any person with problematic drinking behaviors can be amongst the most vulnerable populations to COVID-19. The long-term effects of the pandemic on alcohol use and related harms are another consideration, because normalizing home drinking and reinforcing drinking to cope with stress, anxiety, and boredom might escalate into an alcohol use disorder. And there is already evidence from prior studies of the impacts of pandemics and natural disasters that showed long-term increases in alcohol consumption and related problems. And of course, the morbidity associated with alcohol consumption is huge. Thinking, for example, of alcohol-related liver injury, the higher increases in drinking above guidelines for women is concerning, because women are more susceptible than men to the effect of alcohol-related liver injury. The trend for the past 2 decades already shows that alcohol consumption and problems have increased more among women. Naturally, there is a concern with the exacerbation of these trends with the current pandemic. And so what's next? These results show the importance of monitoring alcohol consumption and policies now and as restrictions are lifted. One question is whether alcohol consumption will return to pre-COVID levels. And another big question is whether relaxed rules on alcohol sales can become permanent after the pandemic. While the measures were largely implemented to minimize physical contact to reduce COVID-19 transmission, they were also made to support businesses by introducing new ways for the public to access alcohol. And if these measures are not reversed post-pandemic, they have the potential to increase population-level alcohol consumption and corresponding harms for the long term. Going forward, it's very important to monitor alcohol attributable harms during and following the COVID-19 crisis. Understanding these harms can aid in optimizing interventions and improving disaster preparedness and responses in the future. It would also be important to, during the pandemic, remind the public of alcohol drinking guidelines and recommended limits on the quantity and the frequency of consumption. And also think of implementing a public awareness campaign that encourages people to drink less or at least not to drink more than usual. And finally, there is a need to understand the connection between policy changes and alcohol consumption. The variation in policies controlling alcohol access create an ideal environment to conduct natural experimental studies that compare the different levels of public access to alcohol and alcohol-related outcomes. This work can help understanding the implications of shifting the level of public access to alcohol in a crisis. And an immediate next step for this research is conducting further waves of the current survey. Now we are going to answer some of the questions that have been posted in a Q&A box, and Arnie Aldridge has been taking notes of the questions. So Arnie, let's start addressing some of the questions, and thank you all.
Now can you hear me?
Yes.
All right. So let's start with the burning practical question. At what point will these slides or a link to the recording be made available to folks? And can we give a citation along with them?
It's the first question that I don't know the answer. That's a hard one, Arnie. I don't know. That's a very hard one.
Well,
They will be available. They will be available. The citation will work on it. When they will be available, I don't know if the other panelists know.
Okay, great. So anyone on this mailing group, you'll be notified once these are available. A related question, again, a little on the practical, and then we'll get to the content. Several recommendations in chat and in the questions about, can this be made into a brief report? And I believe you guys are currently working on a peer review publication for it.
Yes, it's under review currently.
Okay, great. Let's jump to some content questions. First, there's a question about, so the survey asked questions, self-report for February and April in 2 time periods. And to what extent do you think recall bias is a problem or a challenge for the results?
I'll take that first, and then Bill, I'm sure Bill will have to can add to that. But remember that most national surveys that ask about alcohol consumption, they actually ask about the past full year, and they're considered pretty good. And we're simply asking about the past months. The other thing is the way we framed the questions in the survey, we actually anchored into the when stay-at-home restrictions were put in place. So people have so people could think. So we did not just ask, oh, we are now in March. We are now in May. When did we conduct this? In May. But basically, we did ask, remember when these restrictions were put in place? So before, how were you drinking? And after, or currently, how have you been drinking? So it's actually pretty easy for people to anchor their answers on the event. Bill, do you want to add anything?
I think it's a really good question. I think that recall bias is something you'll always be worried about when you're doing a retrospective survey like this. I think we expected, we talked a lot about this, and we expected that any impact it would have, we thought would actually cause the 2 months to be drawn closer together rather than further apart. So if you don't think that, if you only remember your April drinking and you don't really remember your February drinking, we expected that you'd probably expect that you drank similar amounts. But it is a really good question. It's something we wrestled with, and it's the main reason why we really wanted to get this survey out in the field as quickly as we could in early May. So thank you for that question.
Could you guys elaborate a little more on who the population was that was targeted for this survey, and maybe generally who you actually got as respondents to it?
So we used the knowledge panel from Ipsos. These people were recruited through the probability-based process, and they are a random sample, and we use weights so they could be representative of the US population.
Yeah, it is a general population survey, and I think one of the strengths of it is that they do include people who don't have the internet. Even though it's an internet-based survey, Ipsos does have a way to include folks who don't have the internet already, or don't have a landline, for example. So it's a pretty robust sampling methodology that generates. So in other words, it wasn't targeting a certain group related to alcohol consumption. It was meant to be a general population survey.
Great. One of my favorite questions as I've seen you guys going through these analyses, how many non-drinkers started drinking? And how much did they drink?
So we did look at that, as we noted. We excluded people who weren't drinking in February. We already shared with you that about 10% of the people who were drinking in February stopped drinking in April. of the people that weren't drinking in February, about 12% started drinking in April. And we kind of consider that to be, you would expect some natural in and out of drinking, if you would. If you're a very infrequent drinker, you might only drink every couple of months, and these folks just happen to drink in February and not April, or vice versa. I don't have at hand how much they drank, so that's something we would have to go back and look at, but we did want to look at at a sample of respondents who were actively drinking in February to see how the stay-at-home orders and other policies changed their behavior.
Great. You described some of the consequences of alcohol use across society in terms of mortality and morbidity, accidents, et cetera. Fetal alcohol syndrome, or fetal alcohol spectrum disorder, is a very large problem as well. And that might be, given the, changes in, conception for a whole new cohort of children during COVID. What do you think there are any implications of what you're seeing for whether there might be changes in the trajectory around FASD?
That's very interesting. I'm not sure we have well, at the time, we did not ask if any of the female respondents were pregnant. We should have asked. But I don't see a reason not to expect that there will actually be also a very significant impact on FASD, particularly because we have pregnant women that are even more susceptible to stress, anxiety, depression, and everything else that comes with COVID-19 as well.
I'll just note, this cuts across several questions asked in different ways. So we know that for male and female, heavy drinking days are usually 4+ or 5+, but there are other lower risk levels for what might be considered safe daily drinking. And then it does sound like, 1 drink per day for either gender is on the docket for being a recommendation. But do you guys just want to summarize the general idea around groups or consumption risk levels, some of the old ones, the new ones, where you think it might be going, and the relevance to the measures you guys used? You can answer any part of that.
So changes in the recommended limits, where this is going, because that's another.
Well, it doesn't. Sorry, no, not on the changes, but in light of the possibility that there are, more conservative recommendations around drinking, how does that change the value or the meaning of your interpretation of the measures that you guys used?
Yeah, I see. So just to reiterate, the exceeding drinking guidelines is based on 2 measures. So it's not just not drinking more than 3 for women and more than 4 for men, which is a lot. It's also not drinking more than 7 per week or 14 per week for female and males, respectively. So we're talking about 7 per week will be 1 drink a day if we have a female drinking every day. So I just wanted to make that clear, that it looks like the 3 and 4 is very high, which it is, but at the same time, if a person was drinking above the weekly guidelines, which is 7 per week for females, for example, those will be flagged as exceeding drinking guidelines. And the binge drinking, that's the more, that people are, it's more across the globe, that it's no more than 4 for men, or having more than 4 for men and more than 3 for women. Now, in terms of the average numbers, maybe we can pull the, without stratification, the main results. I think we're talking about a change of, depending on the current consumption, of 5 drinks per week. Was that it? Let's pull that slide again, maybe.
Yeah, among people who increase their consumption, they increased it by about 5 drinks per week. So, I mean, for women especially, that's getting very close to that weekly limit, just the increase. That was slide find the slide number. It's in the 30s. It's one of the bar charts. Yep, it's 38. Or no. No, it's not. Bear with me, folks. 25. Slide 25. So across all respondents, 0.2 drinks per day is about 1.5 drinks per week. But among the 41% that increased their consumption, on average, they increased by 5 drinks per week. And that's I think that makes up a large portion of that chain, that excessive consumption behavior, which is why we also saw an increase on those outcomes.
Okay. Just want to, because there was some question, and there's a lot of information to digest. One summary of the main finding is that most people either decreased alcohol consumption or consumed about the same amount, so 50% or more. But a small percentage increased their consumption so significantly that it skews the data towards increased consumption. Is that a good way to characterize one of the main results, or would you add any nuance to that?
It is a good way, but I wouldn't say it's a small percentage that increase. I think 40% is still a lot. It's 40% of the U.S. population increasing consumption. That's, and of course this is significant. That's a lot. Of course it's skewing the results, and then if you look at those that really increase and the changes in those that increase, it's actually very dramatic.
Yeah, let me try. So when we said that 7% group made up 65% of the change, what we meant by that was across everybody in our sample, and we actually added this up, everybody in the sample drank a combined 3,000 more drinks in April than February. So the 7% drank 2,000, so about 65%, okay, of that full. However, 30% of our sample decreased their drinking. So the remaining out of the 41% that increased, they had to make up for the people who decreased as well. So it's not as though 7% increased a lot, 34% barely increased, and everybody else stayed the same or decreased. There were substantial increases. It's just that group makes up such a large proportion of the overall increase. I think it's also important to remember that of the 7%, most of them were not drinking to excess in February. It's important to remember who those people are, and so that the fact that they changed their drinking behavior and now are drinking in excess of recommended guidelines means that there are more people drinking in excess of recommended guidelines, because the people who already were, although they didn't change their drinks per day, are still drinking in excess of recommended guidelines. So it is a cause for concern there. So I wouldn't lose sight of who those 7% were.
Just to kind of synthesize across a theme that I think is useful to speak to, there were questions about deeper, understanding the complex relationships of the policy changes, other COVID-related phenomena, and drinking, as well as questions about how unrest over, health disparities for racial minorities and minority ethnicities. So is there a way that this study can answer those, or might continue to answer those with future additional data collection?
Yeah, yes, that those are other analyses that we will be looking into, and including also future data collection to increase our sample and look at the impact of policies stratified by those key groups that you just mentioned, Arnie.
Somewhat related, there was a question about the relative sample sizes or representativeness by whites versus other demographic groups. To what extent do you think this changes your interpretation or the utility of the results that you're finding?
Our sample was 66% white and 34% non-white. I don't have at my fingertips the US population, but we would expect after applying the weights, well, our full sample would have been very close to the national distribution because of the Ipsos panel and the weights. Our subsample of people who drank in February might be a little bit off because there are differences as we looked at in the prevalence of drinking among race ethnicity groups in February. So that might be why our sample of 555 who were drinking in February might look a little bit different, but I don't think it's off by a large amount. But that's a great question. Thank you.
Did your survey include any questions on other substance use and possible substitution behaviors?
So we did not include questions on other substances. We do have information on whether the respondents were using other substances in the past year, just because it's part of the panel information, but we do not ask about changes in the consumption of other substances.
Mm-hmm. Okay, pivoting now just to geographic differences. Do you have a proposed mechanism for the East-West differential, such as the rate of new exposures or how quickly or strict the lockdowns were, the stay-at-home orders were?
So obviously lockdown policies and alcohol control policies were implemented at the state level, and we just simply didn't have enough sample size to really evaluate that at the state level. I don't have a mechanism, except I think I can rule out. I was looking through the questions and I saw somebody had asked whether people in the Northeast had a higher, higher outcome level in February for any of these outcomes, and the answer is no. In terms of drinks per day, the Northeast region had the second lowest, the South had the lowest, and the Midwest had the highest. So it's not simply that folks in New England were already drinking a lot, or folks in the Northeast were already drinking a lot and just didn't increase as much. So that doesn't explain it, but we struggled with that. I think it's really interesting and something we'd like to do more with to understand why the West region seemed to dominate the change.
Do you guys have any thoughts on the types of behavioral interventions that might be increased or adapted in response to this type of phenomenon of increased drinking that's due to some pretty interesting circumstances?
Other interventions, or which interventions will be better suited here?
Or just, there are 3 FDA-approved medications for treatment, trying to limit drinking within individuals who have alcohol use disorder. But there's also screening and brief intervention.
Yeah, for sure.
In healthcare settings.
Or at home. While there was a lockdown, would have been a great timing for people to get, some kind of a brief intervention delivered at home, telemedicine for sure, and campaigns. But I mean, ideally a campaign that could actually reach people at home, which is the setting where most of us were until very recently. Yeah.
I think, and this is not a question, but just me thinking out loud, it is interesting to wonder, the mechanism of effect of a brief intervention, might work through, external stressors that are causing the drinking. And it's a good open question as to whether, COVID-related circumstances might require a different type of, pattern of delivering a CBT kind of conversation. So, thank you for your answer.
We've reached the,
Could you speak? Oh, go ahead.
We've reached the top of the hour. I think we, unfortunately, out of time at this point.
Yes, so I wanted to thank everyone for attending today, and especially to our presenters as well. If you have any questions that we did not get to today, you see the contact email addresses on the screen now, so you can submit those questions as they come in. And with that, I'll close out the session, and everyone enjoy the rest of your afternoon. Thank you.